Good evening, everyone. Here Aala Abbas. Again, I am live. I am live from Dubai, and today we have Professor Aala Abbas. He's a great person, great teacher, great surgeon, and leading bariatric surgeon at the globe, no doubt. And his role for especially promoting bariatric surgery for education, we all know at any, you can see, international event, professor is there, and his role is a leading person. So just we were talking offline with each other. So about this importance of redo surgeries. Now the time to talk more about redo surgeries and revisional surgery, revisional bariatric surgery. This is the time because now we are facing many situations. So some complications, some side effects, some weight regains, GERD after bariatric surgery, and many things. So just we have started this. Interview series. As my viewers, you know, we already finished 4 interview series, and till this time, we did more than 100 interviews with such legendary bariatric surgeons. And now we will go ahead, and we have started this series with the great Professor Robert Rutledge, and we will continue this series for 6 months. At the end, we will have some obsession. Sir, I will not take your time. Please, sir, over to you.
Yes, it's my pleasure and honor to join the global laparoscopy and robotics activity headed by Professor Imran from Dubai. He's a very close friend and an eminent bariatric surgeon, which we've known each other for many years through the international arena of bariatric surgery. And he is always very up to date in his choices of subjects to discuss and to go through in his meetings and his publications as well. And he invited me to talk today about the revisional bariatric surgery, which is really the subject of the hour, as they say, because the maturity of bariatric surgery over the years of the last 2 decades, the number of cases done all over the world is progressively increasing, secondly to the success of the procedures of the surgery. And undoubtedly, like any other track in life, once you do something so many times, you find that there are some revisional points that needs to be looked at and prepared. And that's why we are facing this problem of this new indication of bariatric metabolic surgery, which is revision. And it is still in the process of being developed. Many successful procedures are being done, but so many points, essential points in the practice needs to be clarified. There's no hard and fast guidelines as yet regarding so many issues in the revisional surgery, whether indications, whether it's which procedure to be done after which procedure, and the outcome of these procedures or outcomes of these revisions. When we sit and interview our patients, we need to be able to be clear with them and to give them an insight about what's going to happen after this revisional procedure as regards the incidence of complications compared to the primary procedures they had before, the weight loss outcome, which is going to be the metabolic recovery, added nutritional problems, deficiencies. So the subject needs a lot of work, a lot of effort. And one of the ways to reach this is to discuss it openly with experts, as Professor Imran is doing. The other thing is to go for a level of evidence, which is the highest level of evidence of having multi-center randomized controlled prospective studies in these different types of surgeries we are going to face, so that we can reach strong grounds of recommendations towards what should be done, when and how, and by whom, as he is going to discuss with us today, who should be qualified to do this, as regards the center, as regards the surgeon, as regards the team, the multidisciplinary team who's going to look after, who's going to make the decision that this patient needs another operation. So there are so many nice topics that needs exploring. Fresh grounds, not been decided as yet, not definitely as he was telling me before we start in the textbooks as yet. We are striving to eventually write the textbooks about these important issues and topics, but to wait for 5 or 7 years from today to find it in a textbook is really not the way that present day teaching and development of younger surgeons is going to be. We have to face the fact that the online teaching and education, especially boosted after the coronavirus time, that we realized how important it is to use this avenue or media of transport of information and the education. I think this will gradually be more and more standardized way of developing the science and progressing in medicine, especially, and surgery.
Sir, excellent. Sir, as you have mentioned, so always a natural disaster, there are some opportunities. It depends on you how you can change that disaster to opportunity. And this social media and also online sharing knowledge is, in my opinion, one of the opportunity of that COVID time. Sir, so much thanks. And so now we will go ahead and also we will try our best in this short period convey our message regarding revisional surgery. Sir, how you define failure of bariatric surgery? Because in this topic, we will talk only about failure, because about complication we will have another 6 months session, because complication is totally leak and bleeding, and that is also a different story. Because in
Yes.
this 6 month we will talk about revisional surgeries. How you define failure? I mean, insufficient weight loss, weight regain, GERD. When you will ask this is failure of bariatric surgery and need to go for revisional surgery, how you define?
Yes, as you said, the revisional surgery is a big umbrella under which go many types of interventions. Some of them are to handle immediate and long-term complications of bariatric procedure, like you mentioned, leak or immediate hemorrhage or obstruction or internal hernias or malnutrition. But the section of revisional surgery regarding a management of complication, you're going to handle separately. But we are interested today in revisional surgery as regards the supposedly failed bariatric metabolic surgery from before. So if we divide bariatric metabolic surgery into bariatric and metabolic, the definition of failure of metabolic outcome is really much more easier to define when the patient had a remission or partial remission of his diabetes, and this becomes relapsing and he needs further go back to his medication, his hemoglobin 1C is going high up. This is clear failure of the metabolic outcome of the procedure. So if you divide it into metabolic and bariatric, the metabolic part is easy. The problem with the bariatric part, which is mainly regarding the weight, can be divided into two ways. Non-responders, which is a failure to lose weight to the target of defined, acceptably, internationally acceptably defined success of losing at least 50% of excess weight loss during the first 18 months after surgery. This is a generally standard way of measuring the success of the procedure. So primary failure, which is non-responders, they didn't achieve this 50% in the first 18 months, are a class or a category. And these are, again, very easy to diagnose. The patient did not lose enough weight at all. But the more problematic way of definition, from my point of view, is the weight regain. Because we all know I've been practicing bariatric surgery since 1996. So in 3 years from now, it will be 30 years. And I've done more than 7,700 different bariatric procedures over the years. We all know the natural history of bariatric procedures. Whatever the procedure you're doing, after the first few years, the patient goes into plateau, and then after that plateau, the patient progressively increase in weight in a small amount of increase and then stabilize. This is the best possible scenario or outcome. But all the bariatric procedures are liable to have a weight regain, which is not acceptable to the patient, to the supervising team. And some definitions came out saying if the patient gains more than 10 kilograms from the lowest weight he achieved, the nadir weight, then this could be weight regain and could be an indication for surgery. Others would try to measure it through the body mass index, saying gaining an increase in the body mass index units of 5 units after achieving the minimum BMI level, then again this is considered the weight regain and considered an indication for a second procedure. But I really have to question this. In my opinion, that's it's a very vague way of defining the weight regain that is not suitable for every case. To try to explain my point of view, I'll put it in numbers to make it easy for you. So if you have a young female who weight was about 95 kilograms, she was short stature, and she had a procedure, whatever it is, and she lost weight from 95 to 65 over the first 3 years of her surgery. Then if she gains 10 kilograms from this 65 and became 75 after 5 years, is this an indication for a second bariatric procedure?
No.
You see, so the rule of having 10 kilograms increase from the lowest does not apply here. Let us put it for a higher BMI, a patient who's 180 kilograms, who lost through his primary procedure 85 kilograms and became 95 in the first 3 years. By year 5, he's 105. Would you ask him to have another operation for this 10 kilograms increase after he was 180? So I think this 10 kilograms number is unfair to the natural history of the condition. We know that the patients, whatever the procedure, even the biggest procedure we have, the malabsorptive procedure, the patient after 5-7 years, when they stabilize, they start to have some rise in their weight. So I think to define the weight regain and failure is more of a process rather than a fixed number of kilos. It is an ongoing process of continuously increasing in weight over a period of time. You put this patient under observation by the supervising multidisciplinary team, watching his eating behavior, his ability to eat, his amount of food he can consume, his sensation of satiety, his attitude in eating, and observe this under supervision of trying to control his behavior by the dietitian, and you get a multidisciplinary team decision as regards this patient is trying his best, but the procedure somehow now after 5 years, after 7 years, after 3 years, whatever the duration is not working for him enough that he's continuously gaining weight. So I think to define the failure in the section, in the group of primary failure who did not achieve enough weight, he was 180, he dropped the 150 and stopped. This is easy. He didn't achieve the 50% and he's steady on that weight, or even maybe started to put on weight, then this is an easy group that you can define easily that did not achieve the 50% in 18 months. The problem, in my opinion, that needs for us to study in the future is this other group, which they responded early on and they started to weight regain, and some surgeons are trying to jump into the second procedure by saying that the patient added 10 kilos, a patient added 5 BMI group. The third group, which is the metabolic failure, again, it's easy to clarify. That patient stopped having diabetes treatment. His hemoglobin 1C has dropped from 11 to 6, and he was steady on that for a year. And now his hemoglobin C is going up to 7 and 8. He's needing medications, and he's progressively getting more serious diabetes uncontrolled. Then this is metabolically fails. Maybe his primary procedure hormonal effect was not strong enough. It was just a sleep, and he needs to add a stronger metabolic directed intervention, surgical intervention to regain the metabolic remission he had and sustain it for a longer period of time. So I think I for myself, at this point in time in our history of bariatric surgery, I cannot define the weight regain which is good enough to indicate second procedure as a number that fits all. In my opinion, when I face these patients, I try to personalize the decision making case by case by a group responsible for these patients, psychologist, dietitian, internist with interest in endocrine, as well as the surgeon, and try to make the decision through the monitoring of patients' weight over a period of time rather than on a fixed number of kilos. He added 10. Maybe he added 10 and stopped adding, and he had some Saxenda with the internist, and he stopped at this point, and he's steady on the new weight. Let's leave him be. But if he was putting on weight every month, he's putting 1 or 2 kilograms, and he's had some help from the psychologist how to handle his eating behavior and desire. He has some help from the nutritionist about the type of food he's consuming. He has some help from the internist to try to add some new medications of the GLP-1 medications and so on. And all these failed, and he progressively kept putting on weight. This is, in my opinion, the one who needs another stronger weapon to help him with his fight against obesity by adding a second bariatric procedure. So I'm sorry that I couldn't answer this in an easy way. This patient's number is finished. I think I'm trying to be a little bit fair to our patients in making the decision for a second procedure, which is, in my opinion, a huge decision. It's a risky procedure. It carries a lot of higher incidence of complications, and many of these second procedures have unsatisfactory outcome as regards the aim of that procedure to lose weight. So your patient going from a sleeve to a bypass, and found that after the bypass he started to gain weight. And we have seen this. He's eating better, the restriction is lost, and the limb lenses were not successful enough, and he had the second procedure and he started to gain weight. So he went through the risk of having the complication of second procedure to end up gaining weight and not losing weight. So
Sir,
I think
excellent. Really excellent. No, you have explained in detail. And also, really, I need such a message from a person like you, especially for our youngsters. Unfortunately, nowadays, because I know someone, not only one, many of the young surgeons, so they are doing redo surgery without any indication. And hopefully, this will be a message for them, because obesity is a chronic disease. And also it differs patient to patient, ethnicity to ethnicity. Now when I am sitting in Dubai, so you can't, it is unbelievable, maybe 10 patients from different countries ideal. So maybe 10 different ethnicities ideal. So one is vegetarian, one is using high protein, one is hybrid. So how I must deal? One has some, I think maybe some depression, some psychological issues. So this amazing. So this MDT role of MDT, patient selection, as you have mentioned, this is the most important. Sir, next question regarding technical consideration in for redo surgeries, because when we do a primary surgery, yes, we about know I will use this type of stapler. There is, but when we are going to do a redo surgery, now the tissue is thick. There is a lot of adhesions. This technical consideration is much different as compared to primary. Sir, it's very important to highlight this point, because if someone is going to do this, he must know about this.
Yes, it's very important to have the technical points in the second surgery in mind, really from the very, very early on time when you're sitting with your patient in the clinic. When you talk to him about the second procedure, you have to mention that the surgeon is going to face these adhesions and these difficulties, which he differs from one patient to another. But even if they have been done by the same surgeon, the response of the body to the first operation may differ. And this should make the interview and the consent for the second procedure be more realistic. Don't corner yourself into saying that this patient has a sleeve, we are going to go and do one anastomosis gastric bypass. And when you go in, you found that half of his sleeve is already in his chest, which was not clear on the previous investigations, even if you've done the best ways of investigation, and you find intraoperative surprises that makes the decision towards a Roux-en-Y gastric bypass and repair of the crura and is a more logic. So you shouldn't really corner yourself when you take the consent and discuss with the patient what you are going to do in one single procedure. You say, we are going to plan to add some metabolic effect to your procedure. You had a restrictive operation which you failed, and this restrictive operation have a hormonal effect, but it's not that strong. We are going to add another technique to the weight loss if it's a second surgery by adding some form of bypass. I'm not sure which one is going to be the best for you. We are going to leave it intraoperatively. And sometimes we go in and we go out without doing anything.
Sure.
Some people have a really frozen abdomen that if you insist in doing this second operation, you end up with a life-threatening complication. So leave yourself a space when you talk to the patient that you are going to plan. You have a master plan that you are going to add to the strengths of the previous procedure to do some added mechanisms of action to the previous operation, but don't corner yourself into a specific procedure because you are not going to be sure what you are going to do, which is best according to the situation of the tissues inside. And you have to be prepared. The most important technical preparation is having the expertise needed for the second procedure. It's not having the right size of stapler or all the colors on the table or with you, or the harmonic and ligature, and use them both at the same time. It is how to use these instruments, the ability to use them successfully, which makes things go smoothly. So developing an expertise in revisional bariatric surgery, it takes a learning curve which is much more difficult and higher than primary cases. It's probably the same in any other type of surgery you have dealt with in our career. If you are doing a primary hernia repair, it's different from a recurrent hernia. It's clear. If you are doing a thyroidectomy for a fresh neck, it's totally different from a recurrent thyroid surgery with previous adhesion. You don't know where the nerve or the vessel. So you first have to prepare yourself for the revisional surgery by going through the learning process with someone with more experience and a bigger number of cases of revisional cases under his belt, and you be quite patient to stick with him and go through the learning process, not by see one, teach one, do one, and so on. This is not the thing that you can hurry. And be sure when you are doing these operations. I still remember one of our Egyptian colleagues who was working in King's College, Dr. Sharif Haqqi. He used to say in his presentation that whenever he have revisional cases in King's College, he's just, as a team, they are very, very experienced bariatric surgeons, I think 3 or 4 with Ahmad and Sharif Ha and so on. When they have a revisional case, they always make sure that there is another experienced bariatric surgeon in the operating suite. Even if he's not scrubbed, he can come in, he can be called easily, and you can join making the decision about different tough situation met intraoperatively. So when you're starting revisional surgery, you have to prepare yourself, and for the first few cases, or according to the situation, you have to make sure that you have someone looking over your shoulder to give you some advice if needed, or give you a hand if needed. you shouldn't be shy about getting help with the decision making for the benefit of your patient at the end of the day.
Sir, this is great message because if someone now also my next question that may be the continuity of this question, who is eligible for revisional surgery? So because now your experience is about 3 decades, your personal experience of bariatric surgery, then as well as you are one of the leading person in revisional surgeries. So how you define the surgeon, especially who is eligible for revisional surgery?
I think it's different in different generations. 5 or 10 years ago from now, when we were doing revisional surgery, we were doing 1 or 2 cases every 3 or 6 months. And we had to go to the tertiary center. We had to go to the most experienced surgeon in the country to do your revisional surgery. But now, because of the huge number of revisional cases, then the younger surgeon can be exposed to the multiple revisional procedures within a week, so they can gain the needed expertise in a shorter time span. But in my opinion, it has to be done still in a center where there are multiple experienced bariatric surgeons, not just one surgeon. If you are doing bariatric surgery as one center, one surgeon, and the rest of the team in this center are general surgeon or doing the rest of the surgery, it's tough for you to do the revisional surgery on your own. You need multiple surgeons, experienced surgeons, and the younger ones belonging to that team, they will probably catch up quickly because of the number of cases you get exposed to in a short time span. So having a fellowship or a mini fellowship for an experienced surgeon to join another center where they have multiple revisional cases every week, multiple surgeons are doing it. So an experienced primary bariatric surgeon, if he joins this team for 3 weeks or 3 months, according to his level of expertise, he can probably be ready. Then when he is going to do it, he has to have a center where there are multiple surgeons, not a single surgeon center to do the revisional surgery.
Sir, excellent. Sir, now my question, because definitely we want to talk more and more, but because we always, in our interview, our target is a targeted question and also a message, especially for our youngsters. So because this is the main aim of this interview series. So now I will switch little more technical and also targeted questions. So in this question, my question is about weight regain after a sleeve gastrectomy. Because still at the globe, the most common surgery is a sleeve gastrectomy, and now we are facing insufficient weight loss or weight regain. We tried, yes, MDT, everything, but still now we decided, because now we are talking, we decided to go for this patient is candidate. Yes, we selected. There is no GERD symptoms in this patient. Okay. See, they are already I have clear. So there is no GERD symptom, only weight regain. How you prepare this patient? Now you are going to do surgery. So are you, in this case, is it necessary to do upper endoscopy? You will go for barium meal or barium studies in this case. And then, so which type of surgery is better option? Patient is mid-age, about 50 plus, healthy, and also there is no comorbidity.
Right. To do for a revisional surgery, and you've made your trials with conservative measures, and you made the decision that this patient is going to force to go for surgery, you finished the, in my opinion, the medical preparation with decision making. Now you have the surgical preparation. If I get your question right, the surgical question, how we are going to define, we have a very big array of different procedures. The sleeve lends itself to have secondary procedure easily. If you are going to change a Roux-en-Y or one anastomosis bypass into a D-Relan switch or one of so, you have the problem of rejoining the stomach together. But the sleeve is a simple, nice operation from the point of view that it lends itself to many other options of revision. But how we are going to choose? I think we have to make a very good preoperative study to the case to find out the anatomy of the sleeve and to confirm the absence of GERD. So if the patient has no GERD symptoms, we know that these patients may well be misleading with endoscopic findings of Barrett's, which is going to be a game changer in your decision making what you're going to do next.
Yeah.
So having asymptomatic patient as regards reflux does not mean that you should skip endoscopy before your revisional surgery. You have to do the endoscopy. It's a must to make sure that the cardia is in place. There's no sleeve migration. There's no associated hiatus hernia. There's no associated hidden Barrett, which is again an important issue in making decisions. Second study would be, in my opinion, the virtual CT, gastroscopy, and gastric volumetry. We used to do the barium meal, but the barium meal, if you compare the outcome, the pictures from that compared to the CT volumetry, you have totally different information, or much more valuable information. You can actually find out the size of the sleeve. You can find out the shape of the conformation, where the area of kink, where the area of dilatation. So when you're going to go for your second operation, all these points are important in the technicality of what you are going to do and in the decision making of which procedure. So if you have a nice sleeve, which is symmetrically dilated, with no stricture in the middle, no GERD, no Barrett at the top, and the patient BMI is above 50, is totally different from a patient with a BMI above 40. If you are in the class where the BMI above 50, then you need your second operation to hopefully to be his last operation as regards long-term efficacy. So you need to go for really a stronger procedure as regards the long-term outcome. And the Roux-en-Y gastric bypass, which is standard configuration of short tubular pancreatic limb, would not be considered strong enough in this case to maintain these patients' BMI below 40 for the next 20 years. Then your options will have to go for higher. As I remember, the steps of bariatric surgery, if you start with putting the balloon at the bottom, then the sleeve, then the Roux-en-Y gastric bypass, then the one anastomosis the gastric bypass, then the SADS, then the DS. So I think if the BMI is above 50 in this patient who has no sleeve migration, no hiatus hernia, no GERD or Barrett on endoscopy, symmetrical sleeve dilatation with no stricture or kink or massive dilatation, so the sleeve is big enough to give him a good amount of protein, and adding a malabsorption suppression will not end into protein energy malnutrition. As we know, we cannot combine restriction with malabsorption. This is a disastrous nutritional situation. So the sleeve is nicely dilated. That permits you to go for SADS, or duodenal switch would be the ideal second operation for such a patient. But if the BMI is in the range of early 40s, not above 50, then this operation will be probably too much for the patient. He may well go through a nutritional problem from the strength of this operation on the long term as regards protein energy malnutrition and multivitamin deficiency, and may well be having a one anastomosis gastric bypass with 150 or 180 centimeters of biliary pancreatic limb would be enough for him to achieve the change from the BMI of 42 to 32 over the next 1 or 2 decades. But as we all know, it's a must in all revisional bariatric surgery to measure the full length of the small bowel, because we have all faced tragic problems of the very short bowel with a long segment of being bypassed, and the vice versa, with a very long bowel and not enough segment bypassed, and the patient does not lose weight. So when you're doing your second operation, you don't want to end in either these two extremes. A patient with 9 meters of small bowel and you excluded 1.5 meters. and he's not losing any weight, or a patient with 3 meters and a half of small bowel and you excluded 2 meters, and this patient is going to hell with his severe malnutrition. So once you decided to do a second procedure, you have to measure the full length to make sure that the food is going to see at least 3.5 meters of small bowel, to make sure that he's going to be nutritionally sound and he's not going to suffer from severe malnutrition.
Sir, excellent explanation. But now, because we have really shot, amazing. Your discussion is amazing. Personally, this is personally, really, I am learning a lot. So now, just touch. I want to touch from your side. Then we will go ahead for next question. What is my question? I want to know your experience, your opinion. So now, patient has no gut. Our also intraoperative, everything is fine, everything okay. And patient is young, patient can tolerate malabsorptive procedure. You can do also OAGB, monostomosis gastric bypass. Also, your excellent expertise for SADI. So what is the main difference? The main difference is this: in SADI, so there is a duodeno-ileostomy, so that is enterostomy. But when we will go gastro-ileostomy, so definite, this is the direct. So which procedure you will select in these two? You can do both.
I have to say that they are very close to each other, especially if you are going to measure the full length of the small bowel, then you are going to avoid the mishaps of having severe malnutrition. In my opinion, with my experience stretching now for more than 7 years in doing the SADS, that the duodeno-ileal anastomosis is much better than the gastro-ileal anastomosis or gastrojejunal anastomosis, as regards having anastomotic ulcer, as regards having stricture at the site of the anastomosis, as regards having the pylorus preserved, so you avoid the dumping, you avoid biliary reflux. There are so many nice advantages of creating your anastomosis in the duodenum, not in the stomach.
Sir, excellent. Sir, just continuity of this, because this is always a question from our viewers. If in a case SADI has need to access to duodenum due to CBD stone, have you experienced now 7 years you are doing SADI? Have you faced such a situation?
Yes, I was just actually in our society meeting 2 days ago. It was a teaching session. I was talking about concomitant cholecystectomy after during bariatric metabolic surgery, and I was mentioning this point. Once we have done a big enough number of bypassing the duodenum, and the end of the common body became inaccessible to the ERCP expertise, we had to go back 20 years to our earlier experience of having laparoscopic exploration of the common bile duct and handling the stones in the lower ends of the common ducts using the colodicoscope, your balloon catheters, and this expertise have been lost in a generation because of the dependence on ERCP extraction. So once you've excluded this, I think you had to go back to this expertise needed, because introducing your scope, laparoscopically assisted transjejunal approach to the lower end of the common bile duct and doing the ERCP that way is really, I think, is much more complicated than going straight to the common bile duct and handle it yourself.
Yeah, sir, this is really great point. If someone is going to do SADI-S, so no issue, you can do, but your facility must have coldoscopy and also expertise in exploring CBD by laparoscope. Sir, we will go next question. So now, just because why I am highlighting this one, because we are facing really on daily basis. My questions are on daily basis we are facing. GERD after a sleeve gastrectomy, patient lose weight. Now patient is not BMI high. Yes, patient is BMI about 25, because patient was before surgery 32, 33. So one person did, this is real case that I am talking with you. So unfortunately, maybe there was no indication or indication. We are not talking about the previous indication of sleep. They did sleep. Now patient is really suffering with severe GERD. And that is also what you will do. Now BMI is 23, 24, normal range. So how you will approach, how will you evaluate this patient, and what will be your surgical step?
I think suffering from severe GERD is really a nightmare. That patients have severe symptoms day and night. They are not able to sleep. It's a real problem that we shouldn't be underestimating, and we shouldn't be just trying to put the patient on medications and leave him be on the side. We have to study these patients properly. And many of these patients have problem with their sleeves, mechanical problems. They have a kink or a strictured area as an incisura or a sleeve migration into the chest. And these patients are surgical indication. You cannot just try with them medications for a while. These are patients that have a problem that will not be corrected without surgery. And all the studies and publications and my own personal experience point out that doing the Roux-en-Y gastric bypass is the best option for these severe GERD symptoms following sleep, especially if the patient already achieved good weight loss. The problem is, you're going to face two problems with this. A reasonable percentage of these patients after the Roux-en-Y will regain weight.
Yeah.
Many of them have lost that weight because of the GERD, not because of the success of the sleep. They are really unable to eat because of the severity of their GERD. And once they have the GERD controlled with the Roux-en-Y, and when the patient BMI is low after this period, you are not going to do an aggressive Roux-en-Y. You are going to do the standard Roux-en-Y with a short biliopancreatic limb. And this is, in this case, the patient will probably definitely gain weight.
Yeah.
And the other problem is, after doing this surgery, you'll have 2 or 3% of your patients still suffer from GERD.
Yeah. Yeah.
And
Yes.
it does happen because Roux-en-Y is not immune from GERD.
Yeah.
And the problem of the GERD of Roux-en-Y, it's even more than the normal GERD, because some of these GERD patients are due to mixed type of fluid. It's not just acid anymore, it's acid and alkaline reflux. And that's why you shouldn't be lenient about the length of the row limb. You have to make sure that this row limb not less than 80 centimeters to make sure that the bile is going to be away from this already inflamed area of GERD. So doing that, the patient is low in BMI, so I'm going to do a biliopancreatic limb of 25 centimeters and a row limb of 60 centimeters to avoid patient gaining weight, losing any more weight. This is actually going to create higher chances of continuity of GERD secondary to a mixed acid and bile regurg. And some people would say that if you are doing the Roux-en-Y, this is enough to correct this patient's GERD situation. There is no need to do crural repair. There's no need to add more. I think this is again unfair if you did not study your patient properly. If the patient had a preoperative manometric study showing a very low pressure at the lower end of the esophagus, the normal pressure, as we all know, between 15 and 40. If your patient having a pressure of 6 or 8 and you only changed his construction from sleeve to Roux-en-Y and left this very weak cardiopharyngeal junction, he will definitely continue with his GERD. This patient need to have augmentation of that area by proper repair of the crura, making sure we have a long enough segment of esophagus intra-abdominal by dissection, getting it down, maybe adding. I'm personally against having the lens prosthesis. I've seen how they remove it. It's a horrendous panic movie to watch. So I have done a lot of ligamentum teres or augmentation to the angle of his with repair, and I have put composite mesh on the crura when I felt it's weak. And we are getting very rewarding outcomes regarding remission of the GERD.
Sir, amazing. So all of my question that I was thinking about these question regarding the role of links and also role of this ligamentaris. So really
I can
amazing,
I
excellent explanation.
I can read your mind, my friend.
Yeah, definitely. So I was just thinking about this. This will be my next question.
I
Sir,
know.
regarding, because another issue that we are also routinely face, especially after OAGB, MGB, because now in Middle East, this is one of the most common bariatric surgery, marginal
True.
ulcer. That is reality. We are scientists, we must be realistic. So because my main practice is OAGB, 60-70%, my main practice is OAGB, we are facing GERD symptoms. And there is marginal ulcer. Yes, we diagnosed marginal ulcer, no response to medicine. So now you have decided to go for surgery, surgical intervention. So in case of Roux-en-Y, my question is about this intractable, first, intractable marginal ulcer in Roux-en-Y gastric bypass, what you will do. And next question will be for OAGB. Maybe Roux-en-Y
Yes.
little difficult to solve, but OAGB may be little easier.
Yes. I think in my experience, the marginal ulcers, probably 90% of them are smokers.
Yeah, yeah,
And if the patient is not willing to stop smoking, in my opinion, the only way is to
change
revert
normal.
into normal anatomy.
Yeah,
You avoid creating any gastrointestinal anastomosis in a continuous smoking.
excellent, excellent.
This is the only way to heal. If you do another anastomosis, making the pouch smaller, making the anastomosis wider, all these technical points, you are carrying a burden of trying to correct a pathology which is not to be corrected because the patient continues to smoke.
Yeah,
You are targeting a different in the wrong direction. So if you have to be honest with your patient, if you are not going to quit your smoking, we are going to join the stomach together again, and we get the bowel down, and we help with your weight loss, go back to your normal anatomy. This is the only way your ulcer will be cured. But if the patient is not smoker and it's an OAGB, then you can revise the anastomosis. And I think, in my opinion, you have to make sure whether this ulcer is acid ulcer or a bile ulcer. Because if this is a biliary ulcer, you have to change the configuration to Roux-en-Y. If it's an acid ulcer, then your pouch is so big and generous, then making a smaller pouch and tighter pouch may be enough. So you may be able to do that by the pH metry over 24 hours in the lower end of the pouch to find out whether this ulcer milieu or the fluid around the ulcer is slipping into a biliary fluid or into acidic fluid.
yeah,
If it's living into biliary fluid, then this one anastomosis configuration should be changed into Roux-en-Y and get this bile away from the equation. And this ulcer you are going to excise, but it's not going to recur because the bile is not there anymore. I think this is for me is a logic way to handle the marginal ulcer.
sir, excellent. Sir, regarding this, if this is acidic base in OAGB, acidic base,
Yes.
there is not larger pouch. Pouch is normal. Pouch is standard pouch. Also, then you will prefer to go for Roux-en-Y gastric bypass.
I think in this situation, if I'm sure that the bile is not a problem, the patient never vomited bile and the pH metry there is acidic, maybe it's, again, creating a smaller pouch, a wider
Yeah,
anastomosis, then the ischemia of the strictured area may be enough, not necessarily going for Roux-en-Y.
sure.
Maybe adding a vagotomy can help.
Sure, sir. Because when I remember when I have interviewed Professor Himpan, because regarding this marginal ulcer in Roux-en-Y, and that was a great debate about parietal cells, and because we have no measurement of these parietal cells, so maybe that this pouch is also not a standard for us. Maybe in that small pouch, in that is not a larger or bigger pouch, so more parietal cells and volume and more acid secretion, as we mentioned. So it's better to go for, and this is a great, in my opinion, message for our youngsters, especially who are doing reduce surgeries. If patient with gait, definite smoker, 90% they are smoker. This is also my personal experience. Go for that neutral anatomy, normal anatomy.
Normal anatomy.
No need to go more and more experience, because he will smoke. Again, he will
That,
smoke, unfortunately.
then
Yeah.
this is the only way.
When
The
he is
best is
not
to
caring,
normal.
so what can we do?
Yes.
Sir, next question regarding malnutrition or severe weight loss after any type of malabsorptive surgery. Have you experienced during this about 3 decades? And what was your first approach for such a patient?
Yes, they are really, really very poor patients, very unhappy patients. And the problem is in our area of the world, in our country, we operate in a central area, and so many people come to have their surgery from peripheral areas away from the center. So they present very late with their malnutrition. And it becomes a very difficult situation, and you cannot rush them to surgery, because if you go directly to try to do any form of surgery, they will die.
Yeah.
So you have to very gently go back to feeding them and replenishing all the deficiencies, and very, very careful about the refeeding syndrome and the hypophosphatemia, which is very dangerous and fatal. So the process of replenishing the deficits is crucial. It has to be very slow, adding calories and proteins very slowly. And eventually, when you sail with these patients over a period of weeks or months, you can start deciding about doing the surgery. And when you decide about doing the surgery, you have to, again, study it case by case. If a patient is already lost so much weight, and you are going to just elongate a limb of bypass for him to make the food see more, may not be enough. And such patients may well be better served by regaining total normal anatomy, because they are so immune suppressed, so nutritionally bad, that any residual disturbed anatomy and physiology of the GIT may be really very harmful to them. But if the patient is started to suffer from some degree of malnutrition, some anemia needing blood transfusion here and there, but the albumin is okay, his vitamin is not so bad, and still overweight, then you can readjust the limb lenses or the pouch size and so on to try to correct his nutritional imbalance, at the same time keep his bariatric procedure to avoid weight regain, and again going for a third procedure to try to get him to lose weight again. So I think this has to be studied case by case, but all the severe cases we have seen, we had to revert to normal anatomy. You couldn't take the risk of leaving any residual disturbed, changed anatomy and physiology. We need to just keep them alive.
Yeah. Sara, excellent message. And as you have, so if I can just explain about the most important is feeding of such a patients. So are you recommend so enteral feeding? So we can go just a feeding gastrotomy, and we put a tube in remnant stomach and we start feeding for the patient, because enteral feeding is very effective as compared to TPN. And also in a country where I am living, so because I am basically from Pakistan, and so definitely there are some issues, economical, socio-economical issue. Maybe in Dubai, I have not such a issue. But again, for our patient, again in Dubai, if this is not covered with insurance, very expensive. TPN is very expensive. If we will put a tube in a remnant stomach and we start feeding, patient go home and they continue for some month, when patient will stabilize, then it is easy for us now to take decision. So what will be our next step? Sir, are you agree?
This is correct for the patient who's not that severely malnourished. You can start enteral feeding directly, but in severe malnourishment and you put this tube and let him home, he will go into refeeding and will die.
Oh.
In the severe malnourishment, you have to start by TPN. And after 2 or 3 weeks, when you've gone over the area of hypophosphatemia, when you got over the risk of killing him by nutrition, then you put your enteral feeding and send him home. Or if the patient is, when he's presenting, is not that severely malnourished, then you start with enteral feeding directly. So you have to classify your patient degree of malnutrition. Will he stand enteral feeding from the beginning, not that severely malnourished, then you start, as you said, directly with the enteral feeding. If it's that neglected and severe, then you need to start for 2 or 3 weeks parenteral, very, very strictly supervised. You have to do the phosphorus level twice a day in his blood, and when he's over this period, then you put the enteral feeding and you send him home, and you bring him after 3 months and you do revision, etc.
Sir, excellent. Sir, how you will see the role of endoscopic surgery for redo? So, what is your opinion nowadays? Definite, we
I
can.
think we have been going round and round in bariatric surgery. We have tried the gastric balloon. When you remove it, it ends. So we have tried I don't see how we claim that sleeves fail because someone left the fundus, and we do endoscopic sleeve and leave the fundus. So I think at this point in time, the endoscopic interventions are an assist to the original procedure. They cannot be, in my opinion, at this point in time, a standalone intervention. But I don't want to really be the old school surgeon who wouldn't accept new innovations. They may have a rule, they may improve in the future to be successful enough that we accept them as intervention. For me, in a revisional surgery, if you're going to do endoscopic, it may be as a test for what you're going to do. So if you placate a pouch and placate anastomosis of a wide pouch, wide anastomosis, and a weight regain after Roux-en-Y, then the patient start lose weight, then you know that these patients is going to be served well by refashioning his pouch, removing his candy cane, refashioning his stoma into a smaller one, and no need to change limb lengths. So it is some sort of a test. But you don't do this plication, endoscopic plication of the anastomosis and the pouch, and think that this is going to work for long. It's just a test that help you to make your choice of intervention, what you are going to do next. But no evidence-based publications as yet to show that these endoscopic interventions for revision are effective enough on the long term, or effective enough even on the short term for a percentage of weight loss that is aimed.
Sure, sir, excellent. But as you have highlighted, so it depends on the technology, and it depends on the benefits of this. So wait and watch policy is better. So at this stage, maybe we cannot recommend this, but definitely with the passage of time, we can see the expertise and role of endoscopic surgery, sir. Because your position is like someone who are decision maker and also especially guidelines maker. So our expectation from you and your team at the globe, so go for guide. I know this is much difficult, especially for redo surgeries. But again, we need roadmap. Already we have lot of studies, but need to more these roadmaps. So how can we go ahead for a redo surgery, sir? At the end, because really it was one of the really one of the best session about redo surgery. So your message for our youngsters who are following GLR and also this interview series, especially redo surgery, sir, please.
I think our youngsters are going to face a different practice from what we have seen in the beginning. When we are as young as they are, we were always doing primary cases, and they are not going to be having the same type of patients. They will face a lot of revisions, which we have done as a primary. So all the youngsters have to prepare for themselves to be looking after patients in revisional surgery. The number of revisional cases is increasing every year, everywhere, and it has to be part of their training and armamentarium in looking after our bariatric patient, as you generously described the obesity of being a chronic. And it's not just a chronic disease, it's a chronic relapsing lifetime disease. So our patients are going to be our patients for the rest of their or our lives, and we have to be prepared to serve them the best way by being well trained in revisional surgery, understanding the multiple factors which go into decision making, patient choice, procedure complications, how to avoid procedure complications, how to look after patients after the revisional surgery nutritionally, and diagnosing their complications if they happen on the short and long term, and be ready to manage them. I'm sure they are going to be better surgeons than we are.
Sir, so much thanks. And really, you are always supportive, you are always encouraging, and definite in our next interview series that will be about complication after bariatric acute and chronic complication. Definite, we will again disturb you, and this is great opportunity for us. And so much thanks our viewers, because this interview series and these academic activities due to your interest. If you have any question from Professor, you can ask in comments. Professor will respond. These all videos we have GLR library, and you can see, you can watch all of this work. More than 100 such videos are in our YouTube channel. And also we have a GLR ebook. And also now on the record, I will invite Professor. I will also share with you the link. Please add your short videos in this ebook. This is amazing work. That is totally digital book. And you can share your tips and tricks of bariatric surgery, any type of. You can add their SADI, you can add your OAGB, your Roux-en-Y, sleeve, any type, redo surgeries. You will be author in that book. And sir, it will be honor. And also we have started now GLR virtual university, that are a short courses with the help of one Malaysian company. And also I will share that detail with you, sir. And also at that both project, we need your support. Sir, again, so much thanks, and have a nice time, sir.
Thank you, and I have to congratulate you for all your effort and all your activities that you serve for other people. Really, God bless you. Thank you very much.
Thank you, sir. Thank you, sir.
Thank you.
Bye.